With that, I don't think I'm going to spend any more time at this, but introduce my dear colleague, David Kent.
Thank you, Harry. I'm just looking for the slide changer. Is that up here? Oh, is that right? Oh, that's a problem because I have a lot of animation. There's no way for me to switch slides up here, huh? Okay. Okay. This is, oh, sorry. Oh, this is forward. Yeah. Okay, great. So, the first thing I want to address is Joe's introduction. I did kind of anticipate the problem with the title, and I think what we're really talking about here is personalized evidence-based medicine. So we're trying to bring the two fields together. The thing I didn't anticipate about Joe's comments was that he'd say this was the most important meeting this year, and I hope that's on tape so I could send it to my mom. But the subtitle is Predictive Approaches to Heterogeneous Treatment Effects, and that's what we're interested in. We're interested in prediction, and there's really two types that we'll talk about on this panel. One is kind of risk stratification, and the other is, or risk modeling, and the other is effect modeling. And so Sanjay will pick up on effect modeling. So we're not the first, really, to point to the limitations of RCTs as providing evidence for clinical decision-making. In fact, 50 years ago, no less an authority as Austin Bradford Hill pointed out that while RCTs can determine the better treatment on average, they do not answer the practicing doctor's question, what is the most likely outcome when this particular drug is given to a particular patient? The innovation of evidence-based medicine was basically to say that Hill had it wrong. RCTs should be used by doctors to determine what's best for individual patients. And I think the most famous definition of evidence-based medicine was offered by David Sackett. He said evidence-based medicine is the conscientious, explicit, judicious, and reasonable use of current best evidence, which is randomized clinical trials or aggregated randomized clinical trials, in making decisions about the care of individual patients. So what they did was very subtle. They proposed to repurpose RCTs from tools to establish causation into tools for prediction in single cases. And as Anne-Marie pointed out, single case prediction is a very problematic area. And a lot of very smart people have thought deeply about them. One of them is Nobelist Daniel Kahneman. He pointed out two distinct approaches. One is the inside view, which focuses on the specifics of a case and weighing all the many characteristics that make it unique, and then synthesizing all those specifics into some kind of prediction. The view of traditional physicians, this is the view that traditional physicians had before evidence-based medicine, and it's really the view we spontaneously adopt for making decisions in all aspects of life. We make decisions every day that we don't have randomized clinical trials or even observation studies to make. The outside view, on the other hand, predicts by explicitly identifying a group of similar cases, which is, i.e., a reference class. And the only way you can make a reference class is by ignoring particulars, by grouping people together that have differences among themselves. The reference class then provides a statistical basis for prediction. And I think there's an abundance of evidence, actually, that the outside view is generally superior than the inside view. And that's what EBM is. EBM is a type of reference class forecasting. It relies on making inferences for single cases based on the frequency of outcomes or estimated treatment effects in a reference class to which the individual of interest is similar. But then there's another very problematic question. How does one define similarity? So that's a rephrasing of what's known as the reference class problem. This was first pointed out by John Venn, mathematician, in 1876. He said, every single thing or event has an indefinite number of properties or attributes observable in it and might therefore be considered as belonging to an indefinite number of different classes of things. And the problem there is that every possible classification scheme will give rise to different inferences for any given patient. So how does evidence-based medicine approach this very deep problem, the reference class problem? Well, generally, I think we've largely ignored it. What we've done is we've emphasized the broadest possible reference class, which is the overall effect in a trial. And if you go to the user's guide, you'll see they say if the patient meets all the inclusion criteria and doesn't violate any of the exclusion criteria, there's little question that the results are applicable. There's another approach, and this was suggested by many people, including Hans Reichenbach, who was the theorist who coined the term reference class problem. So he recommended calibration to the narrowest reference class for which reliable statistics can be compiled. But this actually hides the problem, because if you have just 10 binary attributes, then you have over 1,000 different unique subgroups that you could describe. And if you have 20 attributes, you have over 1 million subgroups that you can describe. And you quickly run into the problem of small sample sizes. So what we need is a principled way of prioritizing what attributes are important in determining the outcome of interest and the benefits of therapy. And this is basically a model selection problem. So one approach that we've been recommending, which we think is a better model than either the overall results of the trial or one variable at a time subgroup analysis, which also ignores the reference class problem, are risk-based subgroups. And I'm just going to discuss why we think risk should be privileged among other variables. Why is risk a better variable than age or than gender or than the presence or absence of diabetes or the presence or absence of hypertension? Well, the main reason is that risk is a mathematical determinant of the treatment effect. If we look, here are 3 different measures of treatment effect: absolute risk reduction, relative risk reduction, odds ratio. And you can see they're comprised of 2 quantities, the experimental event rate and the control event rate. And in particular, the control event rate is just an observable proxy for risk. And if the risk varies across the population, which it always will when you describe it with a multivariate model, then these measures of treatment effect will vary also. In fact, mathematically, you could only hold one constant, and the other 2 will vary, but I presume if we had infinite samples, we'd see that they all vary. This is a risk distribution. These are patients with ST elevation MI. On the y-axis, we see mortality risk. On the x-axis, we see the percentile mortality risk from the lowest risk 0th percentile on the left to the highest risk 100th percentile on the right. This hockey stick-shaped distribution is actually a scatter plot with 1,000 little dots, each representing a patient. And you can see that the overall risk, if you averaged all those dots, and just to give you a sense of how those are computed, it's a logistic regression model based on clinical characteristics like age and comorbidities and the vital signs and the size and the location of the MI. The average risk is 6%. And that's what you'd see in the summary result. The control event rate would be 6%, but what that obscures, I don't know if I could point, but that obscures that 75% of the patients actually have a risk that's lower than the average. And if you look at the 50th percentile, you can see that the median risk patient actually has a risk that's half the average, which would be, so what we've seen, it doesn't take extreme assumptions where the overall result might in some way misrepresent even the typical patient in the trial. If we look at the extreme quartiles of risk, we see the lowest risk 25% of patients has a 1% mortality risk. The highest risk, 25% of patients, has a 16% mortality risk. Frank Harold tells me that that's about a 16-fold difference. He did the calculations. And when you have patients that differ so much in their risk, doctors actually know that the risk-benefit trade-offs in these patients are different, but in a trial they're all lumped together. This is the results of the DYNAMI-2 trial, same population, ST elevation MI. This is a risk-stratified analysis, and you could see that the lines at the bottom of the graph actually represent the 75% of low-risk patients with a TIMI score of 0 to 4. The two lines at the top of the graph show the outcomes in the high-risk patients with a TIMI score of greater than or equal to 5. The high-risk patients, the minority patients who are high risk, get tremendous benefit from PCI compared to medical therapy. But the majority of the patients who are low risk, they're actually slightly harmed by PCI compared to medical therapy. And if you combined in the overall results, the high-risk patients would overwhelm the low-risk patients, right? The large benefit in the high-risk patients overwhelmed the low-risk patients. And when they looked at one variable at a time subgroups, they, just like every other trial, claimed consistency of effects. But that's because they didn't stratify by risk. So you could only see this when you put the variables together and stratify by risk. The interaction p-value is actually statistically significant, but I'll argue that that's done on the relative risk scale and might not be that important. We've looked at many risk distributions across, this is a PCORI-sponsored trial. We looked at 36 publicly available trials, and we actually see there's nothing special about ST elevation MI. All these distributions follow similar patterns. If you're using a Cox model, you get a log normal curve. If you're using a logistic regression model, you get a logistic normal curve. The distribution is defined just by the prevalence and by the C-statistics. So anytime you use a logistic regression model, if you have a 6% outcome risk and your C-statistic is about 0.8, you're going to get a distribution that looks exactly like that ST elevation MI distribution. Besides looking at the distributions, we've also, on the trials that have statistically significant results, we looked at the treatment effects across quartiles of risk. There were 14 trials and 18 unique comparisons. And when we looked at the relative risks, we didn't see any really clear pattern across the risk quartiles. But when we looked at the absolute risk, we saw a fairly consistent effects for increasing absolute risk. This won't surprise people who know algebra. Across the risk groups. And three of them were, we thought were clinically important to report in separate papers. So we have three clinical papers that was published. The first one is the Diabetes Prevention Program, which we published in the BMJ. The first author is Jeremy Sussman, who's here today. This was a trial that randomized 3,000 non-diabetic persons with evidence of impaired glucose metabolism. They randomized them to metformin, a lifestyle intervention, or usual care. These are pre-diabetic patients. The outcome is diabetes. And this is what we saw when we risk stratified the results. Lifestyle comparison to usual care is shown on the left. The y-axis shows the hazard ratio, and you can see there's no heterogeneity, there's homogeneity of treatment effect on the hazard ratio scale for the lifestyle intervention. Everybody gets actually more than a 50% relative risk reduction across all risk strata. But when you look at the metformin arm, you see there's heterogeneity of treatment effect on the hazard ratio scale. The low-risk group gets no benefit whatsoever. The highest risk quartile gets about a 50% relative risk reduction. The intermediate risk groups get somewhere in between that. And the interaction term is highly statistically significant. So we have one intervention where the statisticians will say no homogeneity, no heterogeneity of treatment effect, another where there is. But if we just transform the y-axis into the clinically important measure of treatment effect, which is the absolute risk reduction, we'll see that there's heterogeneity of treatment effect for both interventions. And for both interventions, it's important, it may be important to make different decisions on different patients and to target the treatments to the high-risk group, particularly if resources are in some way limited. And it's important to do that despite the fact that there may not be an interaction p-value that's significant. You still have to make different decisions on these different patients. I'll just show one more. Another trial that we looked at that was in that group was the DIG study. This is an old study that randomized a little over 7,000 patients with heart failure to digoxin or placebo, and the outcome that was positive was hospitalization due to heart failure and all-cause hospitalization. These are the risk-stratified results for hospitalization due to heart failure. You can see the odds ratio in the top graph gets further away from the null as the risk goes up. So more relative risk reduction in the high-risk patients than in the low-risk patients. And of course, when you transform that to the absolute risk in the lower graph, you see that's essentially augmented. And the high-risk group is getting roughly 15 percentage point decrease in hospital admissions from heart failure, whereas the low-risk patients get only a 2% decrease. When you throw in all hospitalizations, you see something interesting. If you look at the lowest risk quartile on the far left, you see that there's actually harm. And this makes sense because digoxin has a very low therapeutic index. These are patients who really can't benefit because they're not at risk for hospitalization. They can't benefit, but they can only get the toxicities that sometimes cause hospitalization with DIG. So there's actually some harm in those patients. So I'm just going to go through the National Lung Screening Trial, but that was an analysis by Stephanie Kowalczyk, published in the New England Journal of Medicine, which I think has been very influential in care. So just to summarize, overall effectiveness results may be driven by a relatively small group of influential, typically high-risk patients. The typical median risk patient is frequently at considerably lower risk than the overall average. The average benefit seen in the summary result often overestimates the benefit on the risk difference scale in most patients and may obscure harm in many. And we found that risk-based subgrouping is often clinically informative, and it's usually feasible. There are now many examples of this in the published literature. I won't go over each of them or explain why that red box is there. But I do want to just finish up with a few caveats. And that is that outcome risk, it's really not the ideal subgrouping variable. Ideally, we would like to model outcome risk with versus without therapy, incorporating all the important treatment effect interactions. But there's a problem with modeling treatment effect interactions, which I'm hoping Sanjay might show. Risk-based subgroup analyses can avoid these problems because it's done blinded to treatment assignment. You could either use an external, already developed model to stratify your patient, or you could make an endogenous model blinded to the treatment effect, and thus that avoids a lot of the really troublesome problems that you see with more aggressive data-driven approaches. And so I'll leave it there and hand it over to Sanjay. Oh, and of course, my collaborators, I'm sure I've left half of them out, but all these people have contributed to the slides that you saw. And my funding source, which is PCORI, of course.